The next thing we're going to talk about is CPAP and BiLevel. So fairly familiar with what CPAP is and BiLevel. CPAP is continuous positive airway pressure, right? The textbooks will tell you it's similar to you driving down the interstate, sticking your head out the window with your window rolled down, opening your mouth. All that air is just rushing in. What CPAP is, there's only two settings that we can put on that device, right? We can put in PEEP, the amount of oxygen we give our patient. CPAP, when we add PEEP to it, all CPAP really is continuous PEEP. It's continuous PEEP that's going into our airway. And we know it's kind of uncomfortable for our patients, right? It causes their eyes to dry out a little bit. Their cheeks start fluttering. It's hard to exhale because they're breathing against all that wind, right? Because all that air is rushing in. What's the purpose of CPAP? Well, I told you can only control two things on it, right? You can control the amount of oxygen you give, and I told you can control the amount of PEEP that you give. The amount of oxygen you give and the PEEP that you give control one thing, right? They control your SpO2, the amount of oxygen that you're giving your patient, the saturations of your patient. So the whole purpose of CPAP is simply to raise somebody's O2 sats. If we can't get a very good mask seal on our patients, we're going to have issues. We also have a lot of issues with patients and anxiety. A lot of times when we put a mask on these patients, it's not very comfortable for them and they don't know what to expect. So a couple things that we can do. First of all, when it comes to anxiety, I think we do a very poor job in EMS, and that's based on my practice. This may not be what you guys do in yours, so I'm generalizing, and I apologize for that if that's not accurate for you guys. But I think we do a poor job of communicating with our patients and telling them exactly what's going on. We're very task-oriented in EMS. When my partner tells me, he looks at me and says, "John, I need CPAP put on that patient," I say, "Yes, sir." I grab that mask, I put it on, strap that thing down as hard as I can, and all right, what's next? So we're very task-oriented. The problem with CPAP is when the patients have never had it before, if they've had it before, a lot of times they're comfortable with it and they've used it, they may ask you for it, right? They'll tell you, "Hey, I want CPAP, I need CPAP." They know it, they like it, they want it, and they'll ask for it. But those patients who've never had it before, who've never experienced it, and we put this mask on them, those are usually the ones that we have issues with. And the reason we have an issue is because if we just take that mask and we slap it on their face, it's uncomfortable, right? They don't know what to expect. They're having a difficulty breathing, right? They're having trouble breathing right now. You're going to take this mask, you're going to put it on their face, you're going to cinch it down really tight to get a good mask seal. It's going to put that big indentation in their face, right? And now they're like, "Okay, I couldn't breathe. This is drying my eyes out. It's causing my cheeks to flutter. You can't understand me. I can't speak. It's hard for me to exhale. This doesn't feel like it's working," right? So that's kind of what's going through your patient's mind. So how do we fix that? Well, I think a lot of times is and I noticed this when I worked in the hospitals and watched all the respiratory therapists there, is if you communicate with your patient, just spend the time that it takes to prepare the device. Talk to them and say, "Hey, I can see you're having trouble breathing. No matter how hard you try to get air into your lungs, it's getting harder and harder. But right now we're worried about getting air into your lungs, and this machine will do that. It is uncomfortable. You have to take slow, deep breaths, and you have to work with the device. If you can get past all that, you're going to notice a result very, very quickly in your machine. If you can do that, I think you relieve some of the anxiety. You let them know what to expect. You let them know that, hey, it's normal that you can't exhale. It's normal that your eyes are going to feel uncomfortable and your cheeks are fluttering and you can't talk. If they know that that's normal, they know to expect it. It's not such a shock anymore, and it doesn't raise their anxiety level. The other thing I like to do is I like to let the patient take that mask and hold it up to their face. You want to condition your patients, right? You want them to condition themselves. So when they take that mask, they're going to say, "Okay, I want you to hold this mask up to your face. If it gets too uncomfortable, feel free to take it off. But when you're ready to put it back on again, put it back on." So what they're going to do is they're going to put it on, and with the very first breath they take, they're going to be like, and then they're going to notice it is a little uncomfortable, so they're going to take it off. And when they take it off, they're going to realize that they can't breathe, so they're going to put it back on again. And they're going to notice it's uncomfortable, and they're going to take it off again. And then when they make that connection, and they say, "I'll deal with a little uncomfortable because I want to breathe," then you've won. Then the natural progression is, "All right, let me go ahead and strap that mask to your face. Now you don't have to hold it." So that's CPAP. CPAP is simply used to increase somebody's O2 saturations. How does it increase O2 sats? By adding PEEP, by giving O2. So I've noticed a lot of times some departments and agencies will tell you that they have issues with mask seal. And mask seal can be a problem if you don't do it correctly. That's where you create some of the mask leak. It's very important with CPAP to maintain a good mask seal because we're giving them continuous PEEP, right? We're putting pressure in. You have to make sure that the mask that you're using is a non-vented mask. If your mask has a vent on it, all that PEEP is just going to come right out of the mask and it will not be able to maintain mask seal. So what is the difference between CPAP and BiLevel? Remember, CPAP is recorded as PEEP, right? We add PEEP to it. BiLevel, they change the terms a little bit slightly. BiLevel, they talk about adding inspiratory and expiratory pressure. Well, I told you they're the same as CPAP, right? So with CPAP, we have 5 of PEEP. Well, instead of PEEP, in BiLevel, we have EPAP, which is expiratory pressure. Because after all, what is PEEP? It's positive and expiratory pressure. So EPAP, expiratory pressure. So that's the same exact thing as PEEP. Inspiratory pressure is the pressure that we cause to get the lungs to inflate. And that is IPAP, I for inspiratory pressures. BiLevel, it's continuous PEEP. So it does everything CPAP does. It is CPAP. So you're going to have a group of patients that fall into all the indications for getting CPAP and none of the contraindications for getting CPAP. But the problem is with those certain subgroup of patients, they're just never going to fly. They're never going to make it on CPAP. And the reason they're not going to make it is because their tidal volumes, they're not drawing enough tidal volume into their lungs. They're respiratory fatigued. They're tired. They're not able to get those tidal volumes. So although we're giving them 5 of PEEP, although we're giving them 100% oxygen, we can increase the PEEP more and more and more. They're not going to make it if they're only pulling 150 cc's or 200 cc's of tidal volume. So the only thing left to us to do is we have BiLevel. So what BiLevel does is it adds an inspiratory pressure to give them the tidal volume they're looking for. And by giving them that tidal volume, I now have some control over their CO2 level, because remember what changes your CO2 level? The rate and tidal volume. I have control of the tidal volume a little bit here by increasing or decreasing the amount of pressure support or inspiratory pressure that I give. They now can be saved from being intubated. Always, always, always refer to BiLevel as IPAP and EPAP, because those numbers are standard. It doesn't matter what your device is, whether your device is PEEP compensated or not. IPAP and EPAP are consistent across the board. So if you want to talk about a machine and you're transferring a patient from one vent to the other or whatever it is that you're doing, always look in terms of BiLevel. If you're in BiLevel mode, look in terms of IPAP and EPAP.